At the top of the hour. All right. It looks like it's the top of the hour now. So, welcome everybody. My name is Amy Graham, and I just want to say thank you very much for joining us on day 2 of week 2 of our virtual conference. Stroughwater is proud to work with rural hospitals from coast to coast, including critical access hospitals and rural facilities in Alaska, Hawaii, and even Maine. So we go from coast to coast on that. And we tackle real world challenges with actionable, data informed strategies. Our work spans financial turnaround, clinical improvement, provider strategy, and capital planning. Today's sessions, we will explore how rural hospitals can rethink emergency department care, OB service sustainability, and facility planning through a future ready lens. Our first session today is with Lindsay Corcoran, Lindsay Hunt, and David Sealander. The title is Delivering Better Care, Practical Approaches for Behavioral Health in SUDs and Rural EDs. And this session will share real world tools and evidence based strategy for improving care for both behavioral health SUD patients in the ED. From process redesign to community coordination, you'll leave with ideas that you can apply immediately. So, with that, I'll turn it over to you, Lindsay.
Great. Thanks, Amy. And good afternoon, everyone. Thanks for joining today's session. As Amy mentioned, today's session is really going to focus on delivering better care for patients with behavioral health and substance use disorders in rural emergency departments. I'm really excited to share some practical approaches and some real world examples that really, really hope to strengthen the care for this vulnerable patient population. And before I really jump in and talk about today's learning objectives, I am going to launch a quick poll for you all. This poll has just 2 questions, and so I'm eager to hear your answers to these 2 poll questions. But the first poll question is really assessing your emergency department and whether or not how long your behavioral health and substance use disorder patients typically remain in the emergency department on average. And then the second question, if you scroll down just a bit, it's what are the biggest challenges that you have for that particular patient population within your emergency department? You can certainly select each individual answer, or you can select all the above or other. And I'll just, as you are filling out this poll, I'll just go into what we're going to cover for today's session. First, we're going to look at the current state of behavioral health challenges in the emergency department. We'll explore some of the key obstacles around workforce, access, and training, and then we'll share some practical proven strategies for improving care, including examples from both rural and urban settings that can be adopted for your organizations. So I'm just going to give it a couple, we're going to wait just about 30 more seconds so we can get that participation up. And if you're just joining, welcome. I know I see some folks coming in. We just have a quick poll. All right, and ending in now. All right. Thanks all for that. It does seem some of the quick results of our initial poll here. A few hours, it was the highest answer for how long your patients typically remain in the emergency department as it relates to your behavioral health and substance use disorder patients. And then the overwhelming majority have indicated lack of community support as your biggest challenge for this particular patient population. As well as length of boarding time, and 30% indicated all of the above. So we're going to touch a little bit about each one of those areas. But first, let's begin. And really, what we know that we need to address behavioral health and substance use disorder in rural emergency departments. And at this point, it's never really been more critical. Across our country, and particularly in rural communities, we're seeing a steady rise in patients experiencing behavioral health and mental health crises, and substance use related emergencies. So really to kick off things, I'd love to walk through some data and some information to just to start to level set, to really drive home the importance of focusing on the emergency department and improving care delivery for, again, those vulnerable patient populations. Really the rising rates of behavioral health in the emergency department, the data is clear. More than 20% of the adults in the US have some sort of mental health disorder. The rates of behavioral health visits in the ED are rising. Rural hospitals, for rural hospitals, really these trends are even more concerning, giving workforce shortages and fewer behavioral health providers and limited access for follow-up care. As it relates to the workforce, more than 1/3 of the US population lives in a mental health professional shortage area. Those mental health professionals include, folks such as addiction counselors, marriage and family therapists, psychiatrists, advanced practice providers, psychologists. Those make up those healthcare professionals specifically for mental health. These shortages also really can impact delays in the emergency department, delays in treatment, and longer and extended stays in the emergency department. Rural emergency departments often are really those safety net care settings for patients that are in crisis, which really can impact and puts tremendous strain on staff and resources within the emergency department. The behavioral health and mental health challenges really today are profound in rural America. And as being rural providers, likely within the audience, there is first a major shortage of behavioral health professionals, as we just mentioned. A statistic that is shown that more than 60% of rural areas lack access to a psychiatrist, and about half have no psychologists available, which really leaves primary care providers, emergency departments, and even law enforcement the only folks that are able to respond to individuals in crisis. And there's also geographic isolation, which really makes things even harder. Rural residents, as you understand, really assess care by having to travel long distances, sometimes hours, and sometimes on roads that are just are not traveled well, which really isn't feasible when you have somebody that is in this crisis situation. Financial barriers also can play a major role for rural patients. Even when care is available, a financial barrier may impede on that care of that patient that may be uninsured or underinsured. There may be delays in treatment. That can contribute to worsening conditions and then ultimately lead to increased ED utilization. And really, something that also cannot be overlooked is the role of stigma. Smaller communities, there is that fear of folks being judged or seen seeking help, and that can contribute to people in not able to or prevent folks from reaching out for care altogether. So all these factors, workforce shortages, geography, cost, stigma, it really continues to contribute to the growing reliance on the emergency department. And as oftentimes the first line for care for folks within these the rural areas of the US, for behavioral health and substance use disorder. So with all that said, this all has a tremendous impact on the emergency department, right? And some key aspects as it relates to the ED is this, notice of a wide variation of staff expertise in training related to mental health. Some providers may feel really confident in managing a patient with a psychiatric crisis, while others may have very little knowledge or very little preparation in being able to support and care for that particular patient. And that gap in that level of expertise can really result in inconsistent care. both patients and staff can ultimately feel the consequences of that variation. And really, second around the data shows that psychiatric patients stay in the ED much longer than other patients. On average, the median length of stay is about 5.5 hours, which is double that of non-psychiatric patients. These extended stays can then contribute to ED overcrowding. There's tying up beds and staff, and delays, it ultimately delaying care potentially for others. And lastly, and third is works we're it is the proposed changes to Medicaid. These are likely to increase the number of patients that have to seek care within the ED, particularly in rural and underserved areas. And this is at the same time where behavioral health resources and access are already limited. So again, all these factors and these issues compounding really highlights the need for consistent processes, better training, and improved partnerships to support both staff and patients in rural ED settings. And then when we also look at the data on psychiatric patients in the ED, it can paint kind of a concerning picture. In a survey of over 300 ED medical directors, nearly 80% reported that psychiatric patients were being boarded in the ED. And a third of those patients were the boarding time stretched to 6 hours or more. So kind of going back to that median length of stay, right, of 5.5, you're seeing, almost a third of those being far greater than that. During that time, the majority, 62%, received no psychiatric services at all. So basically, for extended amount of time, they are just simply waiting. A separate survey of more than 1,300 ED physicians shows how limited psychiatric support really is. Only 7% reported that a psychiatrist actually sees the patient in the ED. So less than 10% of those folks actually see a psychiatrist. And then boarding, we're going to talk a little bit about boarding in just a second, but ED boarding is not unique to just psychiatric patients, but studies have shown that the rates are much higher. About 11% of all ED patients are boarded, but for psych patients specifically, that jumps to about 21%. Psychiatric patients who are boarded are more likely to be readmitted within 30 days, highlighting certainly gaps in care and missed opportunities to intervene. And really, these statistics really reinforce what many of you already experience daily: long wait times, limited resources, and a system that isn't really designed to meet complex needs. So just to highlight a little bit more about the ED boarding, the Joint Commission identified common characteristics of patients who are most often boarded in the ED. Boarded patients often experience or those with severe or persistent mental illness, conditions such as schizophrenia, bipolar disorder, or major depression. And those folks need ongoing and coordinated care. These are not, one-time crisis, right? These are chronic conditions, and they need that continuity and follow-up, which they're presenting in the ED, but that emergency department is likely not the best site of care for these patients. Many of these patients also lack insurance coverage, which limits any options for potential outpatient therapy or treatment, specialty care, community-based support. And then also these individuals have limited social support or community connections, which could mean no family to advocate for them, limited or lack of transportation for follow-up care, no stable housing. Again, making discharge planning, more complex for this patient population. So really, in conclusion, these patients who are most likely to be boarded within the emergency department are also the ones that most need the support. And that's why, this approach around standardized care, early intervention, and community collaboration are so critical to this patient population. So with that, I'm going to turn it over to Lindsay Hunt, and she's going to start to kind of walk through how we begin to really address this challenge.
Great. Thanks, Lindsay. Can you hear me okay? Okay, great. So next slide, please. So we're going to start. I mean, this really brings us all to why we're here today. And uh, the good news is that there's a lot of work that's been done across the country around best practices that both from urban and rural settings that we're going to talk about today, and frameworks that can help to drive improvement in this space. And really, the question is how do we reframe and think differently about this problem and think about it more with the lens of the patient and family at the center. So why don't you go to the next slide? A lot of our learning from this, I want to acknowledge back in 2017, the Institute for Healthcare Improvement, with funding from the Wellbeing Trust, began some innovation work to understand the drivers behind this crisis around behavioral health in the ED. They partnered with health systems from across the country to really identify promising practices and identified some models and some theories of change that we're going to reference today. So if you go to the next slide, uh, so this is a model that's drawn from that work, and again, it really sort of shifts the model into this four-part into sort of this four-part perspective in these four key phases, really starting from the patient's entry into the ED to the point where the patient is triaged and assessed, to the relieving of the distress, and ultimately supporting the patient and family as he or she are discharged outside of the ED. And so it's a valuable sort of shift of frame as we think about this work, which is typically so focused on the system itself. So why don't we go to the next slide? So this is also drawn from that work. And what I just want to draw your attention to, so this is a driver diagram. It's a sort of a theory of change for how to make improvement. And the themes that we're going to touch on today largely touch on the primary drivers in the center. So you'll hear these emphasized throughout the day today, where, really this is about improving processes, standardizing ED processes, looking at provider culture. We're going to talk a lot about sort of how do you create a trauma-informed culture in the ED, engaging patients and families in ED care redesign. And then ultimately, and one of the biggest areas, particularly for in rural communities, is around building partnerships. So strengthening the relationships with community partners, whether those are mental health organizations, public safety, or other partners within the community. So one of our partners in this work, as Dr. Karen Morell, has often asked this question. She's done a lot of work in the space, which is really what other group of patients would be isolated and not actively treated after entry into the ED setting? And it's an important provocation, which raises the question of how do we switch the approach and be more patient-centered in the approach to this challenge. So next slide. And again, this moves us to this new paradigm, which is really around moving from sedate and wait to triage, assess, and initiate treatment. So really, how quickly can we relieve this distress and really with the fact that and address the challenges and the concerns and the distress that's being faced by the patient and family. So so now we're going to show a couple of tool examples. And one of the first related recommendations is really around early medication administration. So this is an emphasis around, again, to the point before, around the importance of working with psychiatrists or other medical health professionals to get agreement around a standard diagnosis-based medication for patients. The idea of obtaining agreement that all patients in the ED over 8 hours would get sort of a nuanced medication assessment, and setting a goal with ED staff to for arrival to medication administration for under 30 minutes for most patients. Again, some of this is some ambitious work, but is sort of some of the best practices in terms of where to work towards. And in this work that came out of Kaiser in Sacramento, they found that patients who were treated early had less agitation, higher discharge percentage, and a lower total length of stay than if hospitalization was needed. Next slide. This is an example of a tool that some of you may have seen. It's called a Smart Medical Clearance Form. It was developed out of California, piloted and studied in California. And the goal of this form is to reduce the number of assessments that patients with behavioral health issues receive when they are in the ED. And so I recognize that in certain states, this is more complicated, but the experience as an example of a tool to be able to reduce the length of stay and reduce the number of assessments that patients receive. In this study, they found that it reduced length of stay per patient for up to between 1 and 3 hours per patient. So, and there are a lot of great examples of things like this out there that can be modified and adapted for your setting. So, and again, so coming back to the patient-centered perspective, really looking for ways to not only triage and assess patients, but examples of relieving distress and lowering the temperature for patients in the ED. So if you go to the next slide, this is another example from Kaiser of a very low-cost, simple messaging tool that was used directly for the behavioral health patients, just helped patients understand sort of what to expect, which was really powerful. This was developed as at a Kaizen event, and it included the entire ED treatment team and their input and ideas. And again, that's part of this work as well, which is really engaging the whole team in developing and adapting these ideas such as this for your unique environment. So this is patient-centered and low cost. And then again, a couple more best practices, the use of telepsychiatry to leverage staff. I'm sure many of you are using this already. Community engagement, again, I think we'll talk more about this, but this is a critical element to really to think about and really test, which is around use as a way to increase clinic capacity and the delivery of medications to the homeless. So also low cost collaboration. So community mental health clinicians can train ED staff in the management and care of patients. Ultimately, what the opportunity is there to really look in your community to identify every community resource and identify and explore ways that you might be able to bring in new partners, think creatively about folks to bring to the
Nope. Did we lose Lindsay?
table to help, including so that was a lot into this. What's that?
No, I think we
Sorry?
lost you for a little bit.
Oh, I'm sorry.
No,
Can you
no
hear me
worries.
now?
Yes, we're good. We're back online.
Okay.
All right. So yeah, so just Lindsay highlighted some of the key best practices as it relates to supporting that patient population within your emergency department. Lindsay, I'll turn it back over to you.
Okay, thanks.
Oh, okay. She's having some audio issues, but now we're shifting gears just a bit, and I'd love to introduce you to Dr. David Sealander. He's the Executive Medical Director of Acute Care and Emergency Medicine with Providence Swedish Medical Center in Seattle, Washington. And he's really he provides this frontline clinical experience and executive leadership. And we are delighted to have him to really share his approach to this work within the emergency department. So welcome.
Hey, good afternoon, everyone. You can all hear me?
Yes.
When I first met with Lindsay, it was really cool to see these slides because all of this work is stuff we did sort of without knowing about all the slides that we're showing. It was best practices, and I think we're going to talk about. You can go to the first slide. My experience, our experience is Swedish, so we are definitely not rural. We're in the middle of Seattle. We have 7 emergency departments. 2 of them are freestanding EDs, but in urban areas. I think there's a lot of the stuff we have done and been successful at that can translate. And the environment we were facing in 2019 and 2020 is a steadily growing behavioral health population with very agitated patients with violent behavior coming in. As anyone who watches the news knows, Seattle is a pretty friendly city. We don't there's we allow a lot of stuff in the city, and our law enforcement was more and more reticent to arrest patients with violent behavior, and so they would bring them to the emergency department. We had a huge increase in workplace violence, a lack of standardized treatment, and then all of this led to cultural concerns around the care of this population. And I think that question about what other groups of patients would be isolated and not actively treated, where we put them aside in the hall, really, really got to me leading the emergency departments. I'm no longer practicing, and I'll fully admit one of the reasons is I was getting very triggered by being called names and a lot of administrative things that triggered me as well. But I wasn't dealing well with the environment, and I didn't want to be a physician in the place that I didn't want to be the type of physician that couldn't treat my patients with the respect they needed. And so I decided that we need to put some structure around this to help the culture. I think a lot of us were getting sort of jaded with the lack of standardization and the violence. So you can go to the next one. So in 2020, we rolled out a pathway. I think we rolled it out on January 21st. We had a strike on January 26th, and then COVID for a couple of years after that. So we had some fits and starts. But it's a really simple pathway that focuses on communication and early treatment and standardization. So we have a huddle with social work, the physician, the nurse, if the charge nurse, if EMS has brought the patient in, get everyone on the same page. We do a score, which I'll talk about more in depth. This allows us to get an objective assessment of a patient's level of agitation and anxiety. One, so it can guide initial treatment, and 2, we can track it. I think as I was rolling this out, we were talking about chest pain. Someone comes in with chest pain, they're going to be treated very similarly at 99% of emergency departments across the country. You're going to ask how bad the pain is, where the location is, and if it radiates. Most people are going to think nitro, even if it may not be the right thing. And we wanted patients with behavioral health complaints coming into our 7 EDs to be treated the same way, where you have a general sort of paradigm around what you think, what you ask, get an assessment, and then for us, think Zyprexa, whether or not we end up giving it. So we do that. We get the medications in as soon as we can if they're needed. De-escalation if you don't need medications. Calm environment if we can provide it. Get the social work or behavioral health assessment. They are mental health providers in Washington. We do not have psychiatrists in the vast majority of our emergency departments. We make a decision on admission or discharge or referral for detention. The county has to detain. Physicians are not allowed to detain in Washington, but we make that decision to refer. And then if a patient's going to be discharged, we get everyone back on the same page, have a conversation, and make sure we haven't missed anything. That last step being very important. There have been times where we thought we had a great plan, and then the patient had mentioned something that raised concerns, and we went back and changed the plan to admit because we were worried about suicidality. Calling this a pathway and spending so much on time on this when we're really just sort of mandating communication and assessment and treatment, which is what we do. It's pretty simple, but we've seen some good results. So if you can go to the next one. I'm going to go into a little depth about the scale we use, which is the Agitation Anxiety Severity Scale. I'm an ED physician, so I super liked the acronym of ASS, and I got to chose it because that's my sense of humor, but it is also a very good score. 17 observable behaviors, both on agitation and anxiety. It allows for nuanced scoring. So some of the other behavioral health scales like bars, you go from sleeping to agitated from a scale of a score of 5 to 6. This really allows you to track nuanced changes. You can indicate medications or de-escalation, predict future escalation earlier. And we really thought it limited the ability for implicit bias to play a role. We know across the country in Prague, we restrain more Black patients than white patients. And we wanted to treat the patients as equitably as possible and limit implicit bias. And because we are able to look at the scale of 0 to 17, we're able to tailor treatment better. What Lindsay was talking about of the medication algorithm, we didn't share that today, but we did develop that with some of our psychiatrists where for a low score, you think about de-escalation or nicotine pouches or coloring books. And for a high score, you might think about intramuscular Zyprexa and really just to guide and standardize treatment and to split it up between anxiolysis as well. So if you can give a small dose of Ativan. Really important here that we philosophically do not believe in chemical restraints. We don't believe that you should ever give a medication just to put someone in the hallway and forget them. You should only give medication with the intent to treat a behavioral health crisis, understanding that sedation can be a side effect. Just like if you give a couple milligrams of Dilaudid, sedation can be a side effect. That may sound like semantics, but it really goes to the culture. And we found that our Department of Health believes that if we are driving medication treatment with this score, it's not chemical restraints, and we don't have to go down the onerous restraint work. So it has been very fortuitous that we are driving treatment with these scores. So if you go to the next one, we have some results. So definitely we've had increased comfort in standardized treatment of ED patients in behavioral health crisis. I think patients come in, everyone expects you're going to get the score. We don't do it 100% of the time, obviously, but there is a framework that we expect people to follow. We do have data to track if patients are getting medications within X amount of time of arrival or within X amount of time of a score of 4 is what we choose. We actually incentivize our physician contracts with either with getting the score and ordering either a PRN med, not necessarily giving, patients are allowed to refuse, but with responding to the score. Decreased workplace violence, this is definitely a correlation. We've had a ton of work on workplace violence, decreased violent restraint use, and then improved regulatory compliance based on what I said before. So when I was thinking about going from an urban to another urban environment or a rural environment, what are the things that I wish I knew or that helped us be successful? The first is to start with culture. It's to start with why. It's to recenter us that while these can be very onerous patients, they are patients in crisis, and we need to provide them standardized evidence-based treatment like we would everyone else. And some unique aspects of the environment to make things calm and comfortable if possible. Setting expectations with a standardized treatment pathway, you get everyone on the same page, everyone knows what to expect. And then really looping back to the culture, focusing on workplace violence reduction. We all see in the news, it seems like every week, where there's been a shooting in an emergency department. If caregivers do not feel safe, particularly around a certain population, they're not going to feel as comfortable interacting with that population. And that can be triggering to everyone, and you just sort of go in that cycle. So those are, I guess, the 3 sort of pillars that I think helped us be successful with this.
That's great. Great, thank you, Dr. Seelander. And can you, Lindsay?
Yes, we can hear you.
Can you hear me? So we're going to invite you to. We're a little tight on time, but I wanted to start Dr. Seelander, with a question just to your last point around workplace violence. And I don't know if there's do you have any sort of specific things that you've done related to workplace violence that might be because clearly that's an issue that folks everywhere are facing. So.
Yeah, so we have this thing called, it's a program that we work with called AVADE, AVADE, which is for the ED in the high risk areas, 4 hours of hands-on training tailored to your policies. And we have seen a decrease in incidents and then a 400% decrease in injuries when there is a workplace violence incident. It's all around de-escalation, a ton of trauma-informed care, and then how to interact and de-escalate the patient population. Feeds into culture, feeds into safety. Number one thing I would suggest would be to have a de-escalation training.
That's great. And then I guess recognizing again that many folks on the line are from rural areas, and do you have advice around how people would get started, or sort of what of these improvements seem like, or you would think of as sort of low-hanging fruit in terms of for folks who want to go back and get started with some ideas?
Yeah, I think burning platform, culture work, saying why it's important, patient stories. I think interacting with NAMI, which is the National Alliance, I think National Alliance of Mental Illness. They have a lot of patient stories. So really, why is this important? What are we doing? What could we do better? And I think the standardized pathway is the way to do it. We, for better or worse, are really good in medicine at knowing and following algorithms, understanding that medicine's an art, and there's medical decision making in there, but providing guidelines and guardrails is the easiest. It's easier said than done, but it's the easiest way to do it. We don't have psychiatrists in our EDs, so we worked on this pathway with psychiatrists, and so it's plug and play, really. We have social workers, but telepsychiatry, telesocial work can help as well. We use telesocial work when we're understaffed. So I think those are the things that in any sort of resource sparse setting are still within sort of the sphere of control. There is a pathway, and then really focusing on the culture.
I wish we had more time. I do see that we're a little tight, so I want to say thank you and sort of pivot a little bit to an upcoming program that we're offering around this issue. And so, Lindsay, if you want to go to the next slide. For those of you who might be interested in diving deeper into this topic, so we're really excited to announce the launch of a new program that's going to be starting this fall. It's a 10-week virtual program, bringing in content experts from across the country and really giving you the opportunity to work with a small team in your critical access hospital emergency department, jump on a call, get ideas, test them in your at your practice within your work environment, come back together and get coaching over this 10-week period. So it's a sort of an improvement sprint, including really some great coaching, and with the goal of really helping you to drive improvement in this area. So if you're interested in learning more, this is a QR code, and there's opportunities. We have our next cohort that's launching in September this year. So encourage you to take a look at it. We'd love to have you join. Let me just see in our final minute. I don't know, Lindsay, are there any questions that have come in?
Yeah, we just had one come in. The audience member asked if we're a large health system with multiple rural hospitals, who would be maybe interested in this sprint that you just spoke of. What would be the best option for us?
Yeah, I mean, that's what's great about this model is it's very flexible. So I think, in improvement work, sometimes it's wonderful to work with new systems or new places. from different areas and learn from them. But this is also a model where if you had, 6 or 8 critical access hospitals and you wanted to run this for your system, we could certainly do that as well. So a lot of flexibility, opportunity to both work within your system or work with other rural critical access partners. So yeah, thank you for that.
Yeah, great. And if there are folks on the line that do have some questions, I know we're just right at time, but if you want to just quickly drop in any of your questions into the Q&A section, we'll be sure to answer those questions and submit them back to you at the conclusion of today's webinar. So feel free, if you had a question about anything that we covered today, just drop it in the Q&A section and we'll be sure to address and you'll receive those emails with the answers. All right.
So,
Amy, back to
Well,
you.
thank you all so much for just, providing these valuable insights on improving ED care for some of our most vulnerable patients. At this time, what we will be doing is we will be ending this session, and you will see a link pop up for our next session, the service line that has been increasingly difficult to sustain in rural settings, and that is obstetrics. So this session will be ending, and I will see you over at the next session. Look forward to seeing you there.